I started looking at antidepressive medication some years ago. First publication was in 1998. And when I first started looking at it, I really did not have an interest in examining the effects of antidepressants. What I was interested in was the placebo effect. I was sure that in the treatment of depression, there must be a placebo effect. After all, one of the causes of depression, one of its most characteristic features, is a sense of hopelessness, and the promise of effective treatment should instill a sense of hope. And I'd always been interested in the placebo effect, so I wanted to see whether we could find a placebo effect in the treatment of depression. I assumed there would be a drug effect that would be a reasonable size, and the placebo effect as well. That led a former student, Guy Saperstein, and I to look for clinical trials in which depressed patients had been given placebos, and also to look for clinical trials in which depressed patients had been followed, assessed, without any intervention at all, because we wanted to make sure we were not just looking at the passage of time, but actually seeing the effect of being given a placebo. Now, where could we find data on depressed patients who had been given placebos? The only place that exists are in the antidepressant clinical trials. And so when we found those data, we had the trial data from the clinical trials for the patients who were given placebo, but we also had the data from the patients who were given antidepressants. We did find, to our satisfaction, and was no surprise to us, that there was a strong placebo effect, and that there was not much change in those patients who had been put on a wait list and were not getting treatment. What did surprise us is that the drug effect, the difference between the response to the drug and the response to the placebo, was very, very small. In fact, it was so small that it was not clinically meaningful. It's not an effect that would make any difference in people's lives. So we published those data, and it turned out to be very controversial. People said, well, perhaps we had not looked at enough data, we had not found enough studies, there are more studies out there, they would show a real effect. And so we went back and we did another meta-analysis, and this was a very special one because what we did was to obtain from the US Food and Drug Administration, the FDA, the organization which passes approval on medications to be prescribed or fails to pass approval. We obtained from them information on all of the clinical trials that the drug companies had submitted to them in the process of seeking approval for antidepressant medications, for what at that time were the 6 most widely prescribed antidepressant medications. And we analyzed those data, and what was especially important, we didn't realize that until after we looked at the data, what was especially important was it included not just published trials, but trials that the drug companies had done that had never been published. And this was the second surprise for me in beginning to look at depression and placebo effect and antidepressants, because it turned out that 40%, 4 out of 10 of the clinical trials that the drug companies had done in assessing antidepressants in an effort to gain approval for antidepressant medication had never been published. These were the trials showing the least benefit of antidepressants. Most of them showed no statistical significant benefit at all for antidepressants over placebos. They had been withheld from publication. And what were published were only the more successful trials, and I have to tell you, even the more successful trials showed a very small benefit, statistically significant, but not a clinically meaningful benefit of taking a drug versus just getting a placebo pill. Well, there's been a big controversy about that ever since, and I think more and more people are coming to realize that whatever benefits people are getting, depressed patients, from taking antidepressant medication, those benefits are not due to the chemicals in the drug. They are mostly, if not completely, a placebo effect, an effect due to thinking that you're getting an effective treatment. So what are we to do? We could, as some people have suggested, prescribe antidepressants because we want to get that placebo effect. People do benefit. The amount of benefit they get from getting either the real drug or the placebo, that's clinically meaningful. But these are active drugs. These are drugs with side effects. These are drugs with health risks. And so it would not be ethical to prescribe these drugs to patients for the benefit of getting a placebo effect and to expose them to these risks. Fortunately, there are alternatives. There are other treatments that don't carry the risks that these potent medications carry, and yet provide at least the same benefit. They provide the same benefit in the short term. They may provide much more benefit in the long term. Perhaps the most popular of these is psychotherapy, and the best studied of them is cognitive behavioral psychotherapy. And there is good evidence with CBT, cognitive behavioral psychotherapy in particular, that this can reduce the risk of relapse, of becoming depressed again. One of the additional problems with antidepressants is that if you do get better taking an antidepressant, in the long run, there's a high level of relapse of people getting depressed again. That's much less true with cognitive behavioral therapy. 15, 20 weeks of CBT leads to improvement that lasts much longer than months and months of antidepressant medication. And there's a way to make CBT, to make cognitive behavioral therapy even more effective, and that's through the addition of hypnosis. One of the principles that we have is that whatever can be done therapeutically without hypnosis can also be done with hypnosis, and the data from clinical trials comparing cognitive behavioral therapy for a variety of disorders to the same therapy with the addition of hypnosis, those studies show that when you add hypnosis, you get a quicker effect and a larger effect and a longer lasting effect. So what would I recommend for people who are depressed, who have not yet entered treatment? Well, first of all, I would ask them what they would like, because an important principle in effective treatment is letting people make an informed choice. But it has to be an informed choice where they know about the dangers of antidepressant medication. Most people, in surveys, most depressed people, given a choice, would prefer psychotherapy to medication. Let them have that safer, more effective choice, and then give them an additional choice. You know, we can do this therapy in the context of hypnosis, using hypnosis to aid it. We don't have to. If the idea of hypnosis scares you, if it frightens you, if it bothers you, we can do it without hypnosis. But some people find that using hypnosis makes it even more effective, and some of the data we have indicate that too. So you would probably be the best person to decide whether adding hypnosis would be helpful or not. And this is what I would say to a client coming in for psychotherapy for depression.